All right. Guys, can you all see my screen with the sternum part showing? The sternum part now, yeah? All right. All right, I won't be focusing on the chat right now. So the focus would be today to learn about the management part, right? Because that gets confusing in the exam as well. We have noticed very closely related options are given. I will be using one of the exam questions as a reference today as well to see after the end of the session how we can apply the concepts that we learned there. And in all the variations that will eventually show up your way, you would be fully equipped to answer them. That's the agenda and the purpose of today's class, to be, address all the questions, whatever exam throws at you, no matter where the attrition is, anterior or posterior, whether the video is collapsed or not, whether the remaining space is available or not, no matter what the presentation, and we learn there are various categories that you can see them. So you would be fully equipped after this class to address any question, any history, any presentation with full confidence. That's what's needed, right? To attempt all the questions in exam with 100% certainty that this is my most reasonable, affordable, conservative, and in terms of accessible to patient and favorable to the patients, and that's my most appropriate treatment plan. Because in the exam what we notice is sometimes they give you both the treatment plans, which may be correct, but complication is which one is most suitable for the patient. So that's what our aim is in today's class. So before I start the management part, I would briefly want to review with you all the types of wear, right? Before we address clinically how the wear presents, how it looks like, how will you categorize it, then it becomes easier for you first to address the etiology, which is most important, right? Addressing the cause, because that's when your preventive stage begins. And once you've addressed the cause, then it will help you decide what would be the treatment plan for the remaining dentition, right? So let's start with knowing the causes and the types of wears, how to clinically identify them, and basically then decide on your treatment plan and address the etiological causes as well. So clinically, I've always taught my students also, it's very easy, though it's confusing, yes, but it's easier when you look at the lesions to broadly classify them as either the cervical lesions or the occlusal lesions, right? Occlusal and incisal involvement. So basically, the loss of surface tooth structure by any chemical action in the continued presence of demineralizing agents with low pH is defined as erosion. So whenever a chemical exposure is happening in the mouth, whether it's intrinsic through your GERD, right, or acidity or any vomiting, bulimia, continuous throw up, all that internal acid exposure leads to intrinsic erosion. And all the dietary acid is extrinsic erosion. The predominant cause in today's world is linked with your extrinsic erosion. So the resulting defective surface is usually smooth. Although erosive agents are the predominant causative factors, it is thought that toothbrushing and or other abrasive agents in the diet can accelerate the loss of tooth structure. So what is believed now that if you see the cervical lesions, the NCCLs, the non-carious cervical lesions, underlying erosion is still the factor which is causing the exaggerated effect of the toothbrushing. So it is mostly now these days known as erosive tooth wear, right? Because erosion is the predominant cause which softens the tooth surface, and then ultimately the attrition because of either age, parafunctional habits, or abrasion due to toothbrushing gets exaggerated. So exogenous acidic agents such as lemon juice may cause crescent shape or dish defects as opposed to the angular on the surfaces of teeth exposed to the agent. So extrinsic erosion usually shows you on the buccal surface of the teeth, like these smooth, shiny facets, right? This is coming from your extrinsic erosive agents. Then B is your general erosion, which is caused by endogenous fluids. The occlusal cupping of your molars is because of intrinsic acids, right? Extrinsic acid shows on the buccal surface coming from the outside. Intrinsic acids show on the palatal surface and cupping of the. So notice this concavity of the occlusal surface. In attrition, due to parafunctional habits, it would be flat and not concave. And these cervical lesions here, the notches, NCCLs, are categorized broadly into abrasion and abfraction. So immediately when you look at the wearers, if you see mostly involved in incisal and occlusal surfaces, it's either erosion or attrition, depending upon concavity or flatness and the history of the patient of acidic drains or intrinsic acids. And the cervical lesions, NCCLs, are your abrasion or abfraction. They're not erosion or attrition, right? So clinically, once in exam, you're given a picture. If you see NCCLs, simply go to abfraction or abrasion and then look for the toothbrushing history and all. And if you see incisal edges involved like this, like cupping and concavity, then it's your erosion, right? And the flatness, the flat occlusal involvement is associated with your attrition. So this is your flat incisal involvement. This is your attrition due to parafunctional habits, right? And sometimes excessive parafunctional habits can lead to minor cracks on the labial surface of the teeth as well. These are known as your enamel phrase lines, right? So far, everyone is able to broadly classify the top categories of the wear, the NCCL, the cervical lesions, and incisal and occlusal lesions, right? So far, so good, right? Because it's important to clinically classify. In exam also, then it becomes super easy, right? When you look at the picture and it's simply, you're dividing it into two. Then you can broadly and can narrow down your further diagnosis by looking at the history. If it's GERD, acidity, then it's your erosion. If it's your TMJ sensitivity, pain and tenderness in the masticatory muscles, and you see parafunctional habit, then it's your attrition. Similarly, for abfraction and abrasion, if there is high occlusal loads, then it's your abfraction. And if you see that there is toothbrushing, aggressive toothbrushing, then it's your abrasion. So abnormal tooth surface loss resulting from direct frictional forces between teeth and external objects is your abrasion. That means an abrasive material, external third force has to be present, which is your toothbrushing in most cases. So loss of tooth structure in cervical areas is abrasion most likely, right? And it is rounded notch in the gingival portion of the facial aspects. So how do you distinguish your abfraction versus abrasion? Is that abfraction is sharp notch and your abrasion is smoother notches. Simple. Because abfraction works on your occlusal forces, there is no third force to smoothen the enamel notch, but toothbrushing smoothens the enamel notch. So smoother cervical abrasions and sharper cervical lesions are abfractions, right? So for that also makes sense for everyone. Now, complete cusp fracture sometimes is also a common occurrence in posterior teeth. And in general, most frequently fracture cusps are your non-functional cusps. So parafunctional habits, which can lead to wear of the teeth, can also lead to cracked cusps and ultimately the entire fracture of the crown, right? And that usually involves your posterior teeth and which is seen in your non-functional cusps. So the most frequently fractured teeth are mandibular molars and second premolars, with the lingual, which is their non-functional cusp, fracturing more often than your functional cusp. Maxillary premolars come second, then to involve in the cusp fracture. Similar to the mandibular teeth, their functional, which is a non-functional cusp, facial cusp, are more frequently involved than their palatal cusp. In maxilla, palatal is the functional, and in mandible, buccal is the functional. So the non-functional cusps are involved more with the tooth wear. So basically, to overview, this is your types of tooth wear, which is seen closely associated with either acidic drinks or with parafunctional habits or with your intrinsic acids, right? So extrinsic and intrinsic erosion. So extrinsic erosion is the external exposure, right? And it is coming from your extrinsic acid. So mostly external surface, the buccal surface with the smooth facets are involved. Whereas the intrinsic acid exposes first the posterior teeth. Coming from the palate, the first exposure is from the posterior teeth. So maxillary and mandibular molar areas are specifically involved, and the palatal aspect of your anteriors is involved, right? And how you differentiate intrinsic erosion, which is the mandibular molar involvement, versus your parafunctional attrition by the concavity or flatness. Attrition happens overall on the teeth, so it is usually flatter surface. Whereas palatal surface and the mandibular molars in the intrinsic erosion is usually washing away, so the concavity is present, right? And cusp fracture, the question is asked, what is the cusp fracture? Can you explain again? So cusp fracture is seen in the non-functional cusps of mandibular molars and the maxillary molars due to excessive parafunctional forces. Sometimes instead of wear, the fractures or cracks can be seen. Does that make sense now? And mandibular molars and premolars are predominantly involved. Then your maxillary teeth are involved, right? All right, so now let's get into tooth wear, which is seen in the population with the aging and what is still the underlying cause, because not aging is always the underlying cause, right? I mean, aging is presenting factor, but in young people also it's seen. And then how you will manage in that. So that's the overall learning that will go on from now. So tooth wear is a common condition. Now let's see about the management. So basically what I'm going to discuss now would be the occlusal management coming from the erosion or attrition. I'm not discussing in this class the management of NCCLs because that's pretty much straightforward, and I'm going to give you that in 2 sentences. So be carefully listen and note it down if you want to. It will apply to exam also very directly. The management of NCCLs, which is 2 categories, abrasion and abfraction, right? Everyone understands the NCCLs are 2 categories, abrasion and abfraction. There's no confusion about that part, right? Right? So let's see. So abrasion and abfraction, the management, initial management and final management. Now, initial management is first desensitizing agents. You have to give them desensitizing agents as the primary or the initial management to seal the tubules, to actually cut off any exposure or any kind of sensitivity to the dentine. And then the final management, if the patient desires the correction of the defects and restorations, the material of choice is your microfilled composite resin. Simple answer, simple management. Everyone understands the initial management and the final management both. The material of choice initially, desensitizing agents as toothpaste, and then eventually the final material to restore them would be microfilled composite restorations. Why microfilled? Because there are flexural forces on the cervical area. If you go ahead and give your heavy duty conventional hybrid restoration, then in those cases they can lead to pop off due to the rigidity of the material. It cannot withstand the flexural forces. So microfilled has more resilience and flexibility to it. That's why that's the preferred agent, right? Desensitizing agents, the most commonly used is your potassium-based, potassium nitrate. They may addedly contain fluoride, and arginine-containing ones are the best ones also, if you can prescribe them, right? So arginine and potassium nitrate are the most effective and the best desensitizing agents available. So that's your NCCL aside. Now let's focus on erosion or attrition based, which is the flattening, and that is what leads to the collapse of bite, basically, right? So can we focus on the treatment on that? Do I have attention of everyone here? And let's focus on the treatment now. So tooth wear is a common condition which increases the severity with age. For many, the gradual change in appearance and shape does not necessitate the need for restorative intervention. So not all wear, remember that, will necessitate an actual restorative treatment. Even the notches and cervical abrasions, sometimes some patients may be happy with desensitization alone. The only botheration could be the sensitivity, and they may not desire the complete restorative management, right? So you need to understand that and keep that in mind, because ultimately the patient's desire is most important when you're planning the treatment. So for many, the gradual change in appearance and shape does not necessitate the need for restorative intervention, but for some, the rate of wear or severity becomes so pronounced that the care should be considered. This can take the form of prevention and monitoring, and then restorations with either composites or crowns. So again, two stages: prevention and monitoring of the cause, right? You will prevent by strengthening the tooth, addressing the etiological factors, monitor whether the wear is progressing at the same rate or not, and then restoration when needed with either composites or crowns, right? So the terminology which is used to describe the wear of teeth has evolved. Now, especially in Europe, the focus is on erosion. As we read in Sturdivant as well, that underlying sometimes is mostly erosion, and then abrasion and attrition only exaggerated. So softening is happening through the dietary acids. That's why diet assessment, and that's why the worldwide the focus of dentistry is focusing to the diet assessment, reducing the snacks, reducing the acidic drinks, because that's the preponderating underlying cause of caries, your erosion, and then erosion leads to exaggerated abrasion, as well as your attrition lead to your normal forces as well. Making sense, everyone, so far? Yes? So the focus is mostly on erosion, and that has meant an acknowledgement that acids are crucially important to the process. In other cultures, the focus has remained more broadly on tooth wear, like erosion, attrition, and abrasion. But to alleviate and find common ground, the term erosive tooth wear, which we read in the Sturdivant as well, has been proposed to capture the meaning. The term is called erosive tooth wear because it is considered as being the predominant underlying cause, right? Even if it's not the dominant way how the teeth will present. So acknowledging that attrition and abrasion remain the causative factors, the etiology will still be either parafunctional habits leading to attrition, or the coarse tooth brushing causing abrasion. But erosion sets the stage. If you now get what I mean, erosion is setting the stage for abrasion and attrition to have even far-fetched effect clinically. So in principle, the level of wear seen in an older patient might be acceptable, whereas the similar levels seen in much younger person may justify care. So sometimes some kind of wear in an older patient, you may feel that okay, it's justified, it's old age, and they may not even worry about giving the crowns. But in younger patient, if you see the similar kind of wear, you might want to think of restorative treatments immediately, right? But if an older patient is a television celebrity or is in an maybe in an field where he requires the cosmetic treatments, then the appearance of an older patient will also require a treatment as aggressive as you may do in a younger patient. So every situation would be different when you're dealing it. Age is not the only factor when you're considering the final treatment, whether it's cosmetic, improving the aesthetics, the professional requirements of patients, their own aesthetic requirements and desires are also equally important. Now, it has been seen that erosive tooth wear or tooth wear is common with up to 29% of young adults now showing some signs of the condition. So it's getting prevalent as well. But it is in older age groups that even shows higher levels of wear as the ravages of time and the use of the teeth impact the shape and the appearance of teeth. There is evidence that tooth wear is correlated to aging, and this matches clinical experience, right? So scoring the level of tooth wear. is also another important factor, keeping the record how it is progressing. And even when the patient is first time presenting you, when you score the wear, you get to assess and you get to know what kind of treatment and whether immediate restorative requirement is there or not, right? So it will help you in understanding the severity of wear. However, in an age where the clinical record keeping is so important, using a scoring system to keep the record, to screen, and to report the tooth wear is essential. The most important scoring system that is used to assess the erosion is the basic erosive wear examination, right? BEWE. Do you all understand? It's the basic erosive wear examination. There is a criteria. You need to see the dentition, assess it, and at the same time, it allows you with the assessment of the erosive tooth wear, and for the reasons given above, it has international acceptance. So if you categorize your patient with BEW criteria, worldwide international acceptance is seen. Then them going to any other country and getting a treatment done, showing their records, it will make sense to dentists all across the globe. So what basically is the BEW criteria? I wanted to slightly take you there so that in your clinical practice and if asked in any exam, you should be able to address it. Can you guys see my browser and the highlighted part here? I want to just double check before I start reading it out. Can you guys see this purple highlighted part? Okay. So basic erosive wear examination is a partial scoring system recording the most severely affected surface in a sextant, and the cumulative score guides the management of the condition for the practitioner. The 4-level score grades the appearance or severity of wear on the teeth from no surface loss, so no wear involved, it would be the scoring 0. No erosive tooth wear. That's healthy tooth, right? Initial loss of enamel surface texture, where only enamel is involved, that's your initial tooth structure loss. It's your score 1. Whereas distinct defect, where the hard tissue is less than half of the surface area involved. So half of the tooth structure remains. That's your scoring criteria 2. And more than 50% of hard tissue lost, that's your most severe kind, scoring criteria 3. So 4 kind of categories: nowhere, initial involvement, less than 50% tooth lost, scoring 2, more than 50% tooth loss is the scoring 3. So in exam, if they give you clinical pictures and they ask you the basic erosive wear examination, the scoring assessment, any questions on the scoring assessment or the type or the criteria or the category they ask, can you make sure everyone knows that, right? Will everyone know and address to that? So far, so good, the criteria. I wanted to cover it so that even when you see a new question on this or you get in your clinics, you should be fully aware, right? All right, coming back to the management part again. So that's your criteria of first clinical assessment. Classifying the wear in aging population, the BEWE score of 3, which is more than 50% of surface involved, present in every sextant, constitutes the severe wear. Once you see in every sextant more than 50% structure lost, it's your severe tooth wear. But in an 18-year-old, the implication is even greater than that of an older person presenting the same score. So with age, the same score can mean different things, would make you think differently in terms of treatment and even in your preventive approaches, right? If the underlying risk factors can be addressed, then wear progression should be slowed and treatment may not be necessary. So first and foremost important in any wear management is addressing the underlying cause, right? Then the wear progression should be slowed, and treatment sometimes may not be necessary depending upon the patient's age and even their aesthetic requirements. This means that for both younger and older adults, the primary indicator for intervention is when the patient feels its impact on their appearance and self-esteem, and then they would like the treatment. The conflict occurs when severe wear is present in young adults who request restorations and who are then expecting a lifetime of use from their teeth. One thing you need to explain to your patients is you cannot expect your dental restorations, whether the composites or your crowns, to perform and be functional in the same way as their natural teeth would be. There would be challenges in the kinds of food they can eat, the wear rate, the fracture risk, the failure of the prosthesis, the failure of the crowns, and each restoration comes with its own period of time that it can last in the mouth. So conversely, someone 70-year-old with teeth worn so severely that they're unrestorable can sometimes struggle between the choice of accepting extractions or no intervention, right? And sometimes a younger patient can have maybe very severe wear, but may require that, okay, give me crowns, but then they should serve me for life. Well, that won't be possible, right? In a mouth where the natural teeth did not survive a young age, expecting a composite or a crown to survive that, mouth would be difficult. So you have to explain to your patients that, where has happened, the damage has happened, we need to prevent it, we need to control it, minimize it. That's half battle one. And then restorative part has its own challenges and would require some kinds of acceptance from the patient that may not last lifelong. So what happens is, as the condition deteriorates, when you see the erosion or attrition, the shape change occurs, right? And then it becomes noticeable to the dentist as well and the patients as well. Now that can present in the form of cupped out lesions, as we saw in the picture in Sturtevant, particularly in the lower first molars, thinning of the facial and buccal surface of the upper incisors. Again, we saw in the erosive tooth wear, the buccal and the facial surface smoothing and the indentations. So which, with more progression, thinning of the palatal and buccal surfaces can lead to unsupported enamel, which can lead to incisor ledges crumbling, fracturing, and ultimately shorter teeth. So at this stage, the process becomes noticeable to the patient as well. When the incisors get involved, that's when the patient also starts noticing and starts getting concerned. But at this point, other changes to the occlusion occur too. Teeth, what happens? So again, what I need to understand the two categories. The wear can be slow and the wear can be rapid. Will you remember these two ways, how the wear spreads, and that will show in effect how the teeth present in the mouth. Rapid versus slow. Will you remember first? So when the wear is happening rapidly, right? The teeth do not have time to supra-erupt and meet and compensate for the lost tooth structure. Rapid wear will lead to bite collapse because teeth are not supra-erupting to compensate. When the tooth wear is slow, the opposing teeth remain in contact by compensation by supra-eruption. So the vertical dimension does not collapse. So there are good and bad sides to it. The wear has happened, the tooth has supra-erupted to compensate for it. The benefit is that there is no collapse of bite, there is no loss of vertical dimension. But the complication that arises is, do you have the remaining space to create crowns without compensating and chopping off the tooth structure? Think about the tooth structure that has been already lost half by the wear. Now the 2 mm further is going to be sacrificed by the dentist to create the space for crown. Do you think that's a feasible management? Chopping the tooth, creating the space for the crowns because there is no vertical dimension loss? Can you imagine it, right? Pulp may not be closer. Now that's a good point. Pulp may not be closer because it's a slow wear. Tooth was supra-erupted and the slow wear gives the chance to the pulp to deposit the secondary dentine. Chambers may be entirely shut down and calcified. That's not your chief problem here. Carletta, if I'm making sense, right? It's a slow progress. secondary dentine, the tertiary dentine gets laid down, the chamber gets closed off, the tooth got supra-erupted, there's no room, vertical dimension is intact. How do you then create space for giving crown? Do you chop off the 2 mm of the tooth structure? That sounds really aggressive for the tooth. Yes, Namrata, that's a good point. You can still raise the bite even despite losing any vertical dimension. It was found that up to 5 mm opening of the vertical dimension can be safe and predictable and can be accepted by the patients. So you can raise the bites, do not sacrifice more tooth structure, and you can still raise the bite without TMJ symptoms, right? Or you could involve orthodontics and cause the intrusion of the molars to gain the space if you don't want to raise the bite. Multidisciplinary approach. Does that make sense for everyone? Yes, when you do the intrusion, right? Then also you can create the space with orthodontic intrusion, and orthodontic intrusion can be either done with fixed ortho or can be done with the DALS concept, DAHL, DALS concept. It's a very vintage concept, but still relevant in contemporary dentistry. Namrata, think about intrusion. Why? Where the video is not lost and the extrusion has already happened and you don't want to raise the bite. Then you will do intrusion of the molar to create that space for the crown, right? Otherwise, go ahead and raise the bite by 2 mm. Your condyles can take it. Your TMJ can take it. Both these senses and both the managements make sense. You will have to select the case exclusively based on the clinical presentation, the TMJ assessment, the intracorneal assessment, time period the patient desires in which the treatment should be finished, cost that the patient desires he can invest. All the factors would go into choosing the path. There is no one way that to address it. That's why it is complex treatment management, right? But you're getting it. Everyone's getting the management and how complex it is, still feasible and possible, right? Now in the rapid wear, what happens is the tooth is not supra-erupted because it happened rapidly. They was not able to compensate. And that leads to vertical bite collapse. In that case, you don't have a problem because now again, that is a double-edged sword. Good part of that is the vertical has collapsed. So you have the space by crowns and simply the bite would be restored to the original vertical dimension, right? You don't have to do intrusions. You might need certain extrusion, in fact, to gain the clinical crown height. And simply the crowns can build up with the rest height. But the drawback of your rapid erosion is that it's mostly very severe, right? And the pulp is also close. Makes sense for everyone so far? So far so good. I know there's a lot to absorb and learn, but that's how intense the topic is, but that's how important the topic is, and multifactorial management is involved, right? So teeth generally tend to maintain contact with opposing teeth when the wear is slow. And if the tooth wear is slow, the opposing teeth remain in contact and sort of over eruption occurs. This results in the shortened teeth without any space to place restorations, making the rehabilitation very complex to provide. The alveolar compensation can be reversed by using such as Dahl's concept, which is again the intrusion of the molars and gaining your space. But it means the restorative process becomes more complex, requires more experience from the dentist, and will be costlier to patient, exactly how we discussed moments ago. So first, a good is making sense. The clinical picture is coming in your head. Now, restorative care. So basically prevention. Prevention should be your first approach when you're working on patients like these. Most dental healthcare providers tend to focus the concept prevention on early wear lesions. They think that if it's early wear, yes, you can focus on prevention then. No. It is recommended that even in the severe cases, you should still focus on prevention. Right? Now look at this clinical presentation. Do you see the chipping and cracks and craze lines within the enamels? Again, due to the thinning, due to the erosion, the palatal erosion, right? And then ultimately this unsupported enamel will collapse and you will have short crowns. That's what's going to happen, right? For rapid wear, I told you, Joylene, because the tooth structure is lost, the space is there to get the crowns, right? So you will start with some sort of supra-eruption or clinical crown lengthening to gain the clinical height to give the crown, but you don't have to create the space. You in fact would want either certain amount of supra-eruption of the posteriors to gain the clinical height, or you would do, so there are two methods to gain the clinical height, either surgical crown lengthening or you would do the orthodontic extrusion. Which is the preferred and the safer method, surgical crown lengthening versus orthodontic extrusion? When you have short clinical crowns and you want to give crowns to graze the bite, yes, orthodontic extrusion is the preferred method, right? Because it maintains the natural zenith of the gingiva, right? And it doesn't lead to the sacrifice of the supporting bone, which would go with the surgical crown lengthening. Now, prevention is appropriate at any stage of the tooth wear process, from the early unworn surface to the most severe also. So justifiably, most tend to focus on the early intervention, but it should always be kept that even in the severe cases, giving preventive advice can restrict further progression. Most of the preventive actions resolve around the toothpastes, mouth rinses, and dietary modification. So this is where the preventive dentistry around the wear is involved. There is a growing body of opinion to suggest that fluoride can either harden enamel surfaces, making them more resistant to erosion, or remineralize your newly eroded surfaces. So incorporating fluoride along with your desensitizing toothpaste and diet modification is considered the recent preventive approach. Overall, it's likely that the toothpaste containing fluorides or calcium-based products, they will reduce progression. So CPP, ACP, and fluoride, they also work together in remineralizing and making the teeth stronger and more resistant to the erosive wear. But probably the largest controllable factor would be still dietary acids. Remove the etiological factor as well. So more recently, the higher risk has been identified as snacking between meals on dietary acids more than 2 times a day. If there are more than 2 snacks going on in a day, that's where the trouble is happening in the mouth. Will you please notice all these things in your patient's history? Yes, extrusion can be done in any age. The teeth are capable to show that, right? Even in older patients, when you extract the tooth and the opposite is left unsupported, within 6 months, it will extrude, Namrata, right? So there is no age associated with this. Now coming back to, if you notice any history of multiple snacking, acidic drinks consumptions more than 2 times, that's a red flag in your patient, and start looking out for wear or excessive, even caries exposures and early demineralization. That kind of changes would be happening in the mouth. Let me take that out later. Let me progress to SSK. I'll get back to that. So changing diets is a challenge, but when successful, it should result in the progression of the tooth wear becoming part of the aging process and no longer becoming the pathological process, right? And it will not affect the longevity of the teeth. Now, possible treatments for your tooth wear. Material that you can go ahead and use, composites and crowns. We know we have 2 treatment choices. Let's talk about composites, where you can use them, what are the challenges and the problems that you may face with them. So resin bonded composites absorb the underlying color of the teeth and they mimic the natural color, creating a pleasing result. Additive techniques have proven to be popular, and on the whole, they create an acceptable result. However, increasing clinical evidence suggests that composites are still brittle, right? They're liable to fracture, especially when the parafunctional forces are in play, and they require replacement. And if it occurs regularly, it becomes time consuming and a very expensive procedure for patients. Many patients will readily accept a minimal intervention where you can just preserve the tooth structure, what's remaining, control the sensitivity, give them strengthening and fluoride and remineralizing toothpaste and desensitizing toothpaste, and control their diet. However, if the repeated fractures and breakages carries a cost which is borne by the patient, and provided this is an irregular expense will be acceptable. So only go for composites where the patient is readily accepting the challenges and the shortcomings of composites. If the restorations require replacements every few months, then composite is not your treatment of choice. You should rethink your treatment. Maybe the crowns may be required. But again, in tooth wear, preparing the tooth over for the crowns sounds counterintuitive, basically, right? And today's world's dentistry is about not touching the remaining tooth structure. More inclination is to the adhesive dentistry for sure, even retaining unsupported enamel to an extent to get that tennis racket benefit. So the entire approach of the world is shifting towards not touching the remaining tooth structure. So giving crowns in anterior teeth, especially those which are afflicted with tooth wear, is counterintuitive, but definitely if the aesthetic demand is higher, you're going with that, and we are giving that, right? So provided the patient accepts the compromise, which is with the composites, the continual maintenance and repair and replacements, the acceptability of restoration remains, but this may not be accepted by every patient. Now, the other possible treatment is the crowns. As you can see here, anteriorly crowns are given. Preparing teeth for crowns is destructive and irreversible. Once the restorative cycle with the crowns has started, it is not. Oh no, absolutely, Shivani. Who would want gold crown in the anteriors? We're talking about anteriors for now, right? Right. So once the restorative cycle has started, it's not possible to go back and allow things to deteriorate again. Under ideal clinical conditions, crowns and bridges can last 10 to 15 years, and maintenance is definitely less than composites. If composites are continually failing and they need replacing with another technique, well, we are only left with an option, which is crowns. Also, where the tooth wear is severe with more than 50% of crown lost, composites are not your material of choice. They will not survive, particularly if there is an underlying bruxism component. So an early assessment at the initial visit should be made on how much tooth structure remains available. So BEWE will come in handy in the initial stage to have your future treatment plan in head. And if the tooth height is too short, additional crown length is needed either from surgical repositioning of gingival tissues, which is also known as surgical crown lengthening. Am I correct? If you have short crowns, you'll need surgical crown lengthening. And then if more than 50% of tooth structure is lost, you also need a post to give a crown. Yes. You will also need a ferrule and a post. However, yes, it can be done in anteriors or posteriors. If you can extrude, if the patient has that cost factor, because see, orthodontic extrusion is expensive. It requires 3 to 6 months cooperation of the time. So not all patients go for orthodontic extrusion, right? It is the preferred and the conservative method, but is it done always? Answer is no. Surgical crown lengthening may be chosen by the patient, being a single step procedure. It's cheaper than the orthodontics and faster. When only core and crown is required, when more than 50% or at least up to 50% of tooth structure remains. Perianal, if you get your answer, right? Got your answer? If up to 50% or more tooth structure is remaining, no post is required, only core and crown. If less than 50% is remaining, a post will also be needed. That goes for the posteriors as well as the anteriors. For crown fracture cases, even with the crown destructed with the caries, applies to all. It's a tooth structure concept. Clear for everyone? The post requirement, where the crown lengthening is needed. Okay. However, if the latter is planned, the role of bruxism, which may be involved with tooth wear, needs considering, as clenching or grinding can overwhelm the material which are used to restore teeth. So again, post is also very sensitive to bruxism. So your underlying causes and all your parafunctional, the entire assessment and clinical investigations are really important to case select and ultimately plan the treatment. Ferrule is missing, See, Avanika, ferrule is the remaining tooth structure. If ferrule is missing, you don't have clinical crown height. You have to do either extrusion or surgical crown lengthening. When you do crown lengthening or you do extrusion, automatically you obtain ferrule, Avanika, right? Yeah. So maintenance. Okay, sorry, I think I missed that part. So when the latter is planned, the role of bruxism should be assessed because that can compromise the crowns. Surgical crown lengthening is uncomfortable for the patients, but creates optimum crown height, providing that the periodontal condition of the tooth is healthy. So even case selection for crown lengthening should be done meticulously. Once the treatment is completed, the patient should be aware of the need for good oral hygiene, maintain regular checkups, and consume low karyogenic and acidic diet. Xerostomia is common in elderly patients and increases the risk of dental caries. Motor skill difficulties, which would impair the oral hygiene around restoration, should be identified from the initial visit, and methods to overcome any difficulties should be discussed. Cost is a very important factor, especially the periosurgery part, the crown lengthening part, or the orthodontic treatment involvement. Then the crowns get material is expensive, especially if you have bruxing, then you would go for the brux, zirconia, that kind of heavy duty materials. So all these are expensive materials. A lot of cost is involved. It's a complex multidisciplinary treatment. Orthodontists, prosthodontists, general dentists, the restorative dentistry, all factors are involved. So patient has to be explained that it can get an complex and expensive treatment and they should be in for it once they get it. Especially with the crowns, it is a permanent irreversible treatment. Once they start it, they will have to maintain it, right? So that's why most of the patients may only go for prevention and monitoring, right? Because it's a complex and a lifelong commitment is needed from the patient's aspect. Prevention is the most important intervention, whether it is with fluoride or with remineralizing solutions or with dietary modification. Restorative intervention is expensive and at risk of failure because of the interplay of erosion, attrition, and abrasion. So you understand that it's expensive, it's time consuming. Najeen, I'm going to talk about that now, right? Now let's look at one question and that will explain Najeen's answer as well and will also help you to think broadly with. So look at this case here. Bruxism, which led to attrition, which led to loss of 50% of tooth structure. You would give a post and preferably zirconia crowns. Yes, if the patient is committing to the cost and the repetition and the maintenance. Otherwise, do not touch them. Leave them in the confirmatory approach, maintenance approach, preventive approach. Just tackle the sensitivity. If pulps are involved, tackle the RCTs and leave them as is, Namrata. Right? If it starts, if you go with the rehabilitation, it is expensive. You would require the patient's commitment in terms of cost and time and repeated appointments. Now, let's look at this question. It was an erosion question in the exam, and there was this question. Let's focus on the second question here. It's an erosion. There has been video lost by 4 mm, must have been rapid for this patient because the video has been lost up to 4 mm, right? There are certain missing teeth as well. The premolars and the first molar here in the maxilla are missing, right? Do you see the presentation? So you decide that composites, you're going with anterior. So there is also attrition and erosion in anterior. Anterior are also collapsed. Posteriors are also collapsed. Certain posteriors are missing as well. 4 mm bite loss. So what do you have to do? You have to raise the bite. You have to gain the clinical height. You don't want to raise the bite. You want to rest. You have to increase the video by 4 mm, right? And anteriorly, you've decided that composites are being given. And there are certain posteriors which are missing as well. So you are going to give a prosthesis and an RPD for those missing teeth. Is that correct? Missing teeth will be replaced by an RPD, prosthesis. Anteriors are being replaced and the height is being built by composite, right? That's what is clinical presentation. So the RPD will be made after the final video is established. Is that correct? RPD will be fabricated after the anteriors and posteriors have brought and are fully given crowns and the entire video is established. You can wait for the RPD after restoring the 7s and the 8s that are still present. 7s are present in the maxilla. 6 and 7s are present in the mandible. So we still have 6 and 7 contacts in the left quadrant. In the right quadrant, we still have the 7 contact. If not contact, at least the molars are still present. And we are raising the bite by 4 mm. So how will we raise the bite? By supra-eruption. Is that correct? Partly we are raising the bite by supra-eruption. Partly we'll raise the bite by giving the crowns, right? You cannot expect the entire 4 mm bite raised by the supra-eruption. Otherwise, how will you get the space for the crown? If the total height is being increased by 4 mm, if 2 mm is the thickness of the crown, the 2 mm has to be compensated by supra-eruption of the posteriors. Yes, absolutely correct, SSK. Other people also, you get it? If you are raising the bite 4 mm, if you supra-erupt 4 mm, where will be the space of the crown? So you have to keep in mind 2 mm is the space of the crown, so rest 2 mm is coming from the supra-eruption. So you have to raise the video with acrylic appliance with the missing tooth. Yes, could that be done? You give maybe a temporary removable appliance in the mouth, in the missing teeth, that separates the posterior by 2 mm. Is that doable? Yes. But would you wait for a period of 2 weeks? Is the period enough of 2 weeks? That's the catch here. It needs at least 3 to 6 mm to lead to the supra-eruption after separation. So 2 weeks period is not enough, but raising the video with acrylic appliance by using the missing teeth space could have been done, but cannot be done with 2 weeks. That's why A is incorrect. The catch is in the 2 weeks. That makes it standing incorrect. Posterior Dahl's appliance. We want to supra-erupt posteriorly, so we are actually giving the Dahl appliance anteriorly. We will give the composite bite plane, anterior bite plane anteriorly to actually separate the posteriors, and then the supra-eruption happen. That's the Dahl's concept. Can you see the picture here, image here to explain the Dahl concept? Anteriorly, posteriorly, you want to raise the bite, you put a composite yellow block here. You separate the teeth anteriorly, right? When you put a composite anterior bite plane here, see that the posteriors got separated, you raise the height. How will that get compensated? With the supra-eruption of the molars. Do you see it here? Can you see my screen, the Dahl's principle? So when you put the posterior Dahl's appliance, basically that means you're giving the bite plane posteriorly. That is used when you want intrusion of the molars. Wherever you put the Dahl appliance, that place intrusion happens. And what gets separated, extrusion happens. So posterior Dahl appliance will lead to intrusion of molars. That is not desired result here. Where will you use posterior Dahl appliance? Anyone can here make a random guess or a scientific guess. Where would you use posterior Dahl appliance? Why would you require intrusion of posterior molars? Two indications are there. Yes, one, when you require extrusion of the anteriors in the anterior open bite. Other, when there is a slow wear and you want to create this space for the crowns. When there is no loss of vertical dimension and you want to create space for crowns in cases of wear. That's the second indication of the Dahl's appliance. That makes sense? So posterior Dahl's appliances require when the video is not lost. In that case, in the current case, we are required to increase the video. So it again is not the treatment of choice for this case also. Makes sense for everyone, yes or no? Is it getting distinctly clear, the clouds disappearing and the management becoming extremely clear? Which will be the more pronounced, intrusion of molars or extrusion of anteriors? Mostly it happens simultaneously. That's the target. And it can vary patient to patient, but with 1 mm of extrusion happening, 1 mm of intrusion is compensated. But 0.5 mm variation can happen patient to patient. Now, can you give anterior composites build-up, which will separate the bite and lead to posterior teeth to re-erupt? Can that be your treatment choice? Yes, because anyways in the question says that you have planned composite restorations in anterior, so you use it also as a separating agent, no? Give it at a height so that it separates the posterior 2 mm and it gets supra erupted, and then rest of the 2 mm you provide by the crowns. And other management could be the stabilization of risk factor reduction, but because it says to wait 12 months for stabilizing the risk factors, no. Stabilization of risk factors should actually begin immediately, even before starting the restorative part. So D also stands incorrect unless the wait for 12 months was not there. So I've highlighted this here because I wanted to emphasize to the students that if the 12 months wait was not given, stabilizing the risk factor reduction is the number one importance. Is that correct? As per all the management that we studied now, prevention and management and reducing the risk factors and the causing factors is the most important and mandatory step for all stages, all ages of the presentation of wear. Am I making full sense for everyone here? And then replacing all the premolars with RPD and allow the rest of posteriors to erupt. Well, could have been done, but if you make RPD at a certain height, we are not sure how much the patient's eruption would happen, right? That's why the after stabilizing the bite and giving the crowns, once you know, because even in slight 0.5 mm variations, your RPD will be left useless, right? If your final does not happen at the same height that you were expecting. D's first and C's second answer, yes, but D is incorrect here because you don't have to wait 12 months for that, May. You will choose D only as your correct answer in the exam if wait for 12 months was not part of the statement. You have to understand that exams can give you various changes in the options. Language can change exam to exam. The variations can happen. One time they give you wait for 12 months in September, they might not give you. The March, they can give you. The same center, they can give wait for 12 months. The other center, they cannot give wait for 12 months. That's why the concept needs to be clear rather than mugging up what is the correct answer. It can change center to center, right? And always stabilize the wear worn off teeth first and then replace the missing with the final established occlusion. That's why E is also not correct. Understood? Everyone gets it? Thank you so much. And that would be it for today. And what I'm planning to do is I'm going to think of other topics which we can cover in the March. So mostly the mentorship class will happen on the last week of the month, Saturdays. How can we manage if the incisal third of the central incisor is palatally worn due to attrition? Two managements again. First, prefer composites. The name of the, what is the name of the student who asked? Leo. Leo, palatally, if cervical loss is there, composites are the best choice. Number one, why? Because of course, there is not as much wear happening or there's not a lot of forces acting on that area. So composites can really survive there. And of course, it's minimally invasive, conserves the tooth structure. I don't think in the cervical involvement of the palatal area, crowns should be ideal because so much of preparation will go on. Composites definitely should be your first attempt. But again, explaining to the patients that there may be challenges and you'll have to see how they withstand the oral environment, right? So to summarize what we have done here is that first, we did the various kinds of wear, the erosion, attrition, the abrasion, the abfraction, right? Then we went on and we studied the management of, I gave you the brief of the NCCL management, the abrasion and abfraction, which is with your microfill composites, right? Then we went to study on the anterior teeth restorations and managements in cases of severe attrition, right? Which would be either with composites or with your crowns. And then we also studied and learned about the posterior molar tooth surface loss, the Dahl's concept, the raising the bite concept. Well, where can you read more on this? I mean, you can find various sources, prosthodontic resources about raising the bite, the full rehabilitation, Ashan, if you want. That depends upon how complex treatment management you want to understand. I have this another article. Let me share the screen. I'll share this on the group also if you want, on my WhatsApp group. Just look at the screen. Which talks about the prosthodontic component, also the articulator component and everything. Can you see my screen? This article where I briefly showed you the Dahl's principle, it has more of the orthodontic management, intrusions, and taking the jaw relationships. I mean, that goes the complex part. That's where goes the complex part. So I'm going to share this one as well with you. Somebody who's more interested in completely getting involved with the management of prosthodontics and ortho. Even as a general dentist, you can be part of that. So I'll share this article as well. I'll share the tooth wear and aging article, this tooth wear article, Sturdivant's, I'm sure you all have it. So that's where you can find it. Yep, so that's about it. And I hope I made some sense. And if you take even 2 cents out of it, that's half my job done. At least it's a successful day then. And I hope you keep learning and keep your curiosities up. Join me every month if you're not already part of my group, but join me once a month to learn the actual valuable concepts in dentistry, and I'll be happy to help you. Thank you so much, guys. Thank you for being part of this day and session. Totally grateful for your contribution. It's all you, because me alone, if there's no one receiving the information, it doesn't make sense, right? So thank you for being part of it. Link for the group. Okay, for the WhatsApp group, Mohit, are you on my Facebook group? I can share my WhatsApp group there as well. So Mohit, are you on my Facebook group or are you on my WhatsApp group? I can share the link for both on counter mediums. So if you're on Facebook group, don't worry, I'm going to share the articles there also, right? So don't worry, I'll be sharing the articles for you to study even on the Facebook groups. Don't worry about that. All right, thank you guys. I'll see you next month. Keep updated yourself with the articles and the information that I post on the group so that you are aware of in the next classes. Yes, I'll share everywhere, right? I'll share all the articles everywhere. All right, thank you so much, guys. Thank you for being the part of my day, and thank you for taking out time from your day. See you guys next month. Bye-bye. Thank you.